Good afternoon, everyone. So today I'll be talking on the management of low-grade non-Hodgkin's lymphomas, which are also called as indolent non-Hodgkin's lymphomas, with emphasis on CAR T cell therapy. So low-grade or indolent non-Hodgkin lymphomas are non-aggressive B-cell lymphomas. They have a slower growth pattern, and they are characterized by two important and peculiar features. One is they have a longer median survival, median OS of 5 to 10 years, and they have a tendency for repeated relapse despite initial response. They'll be responding, but they have the responses are spotted by relapse. And the major subtypes are follicular lymphoma, which is the commonest, around 20 percentage of the non-Hodgkin's lymphomas, and marginal zone lymphomas, which include extranodal, nodal, as well as splenic marginal zone lymphomas, and lymphoplasmacytic lymphoma, Waldenstrom's macroglobulinemia. And the typical presentation is they have a painless lymphadenopathy, which is often incidentally diagnosed. And 60 to 70% of the patients, they are at stage 3 or 4 at diagnosis. So the symptoms are very less that they present at a later stage or an advanced stage. And they have relatively lesser B symptoms compared to aggressive lymphomas. And these are often CD20 positive. So for prognosis, we for follicular lymphoma we use FLIPI, follicular lymphoma IPA index, and it has age more than 60, higher stages, stage 3 and 4, anemia of hemoglobin less than 12, LDH of more than LDH which is more than upper limit of normal, and more than 5 nodal sites. And the indications of treatment is by GELF criteria. GELF criteria includes more than three involved sites, which are more than or equal to 3 centimeters, and mass more than or equal to 7 centimeters. Presence of B symptoms, splenomegaly, leukocytosis or cytopenias, and pleural or any effusion. So these form the indications for treatment. And regarding the diagnostic workup, so biopsy is essential and excisional biopsy or incisional biopsy is preferred compared to core biopsy with immunophenotyping. And we also do molecular studies, BCL2, BCL6 fish, and immunoglobulin gene rearrangements. Apart from that, we have routine CBC, LDH, and comprehensive metabolic panel, including LFT, RFT, urea, and electrolytes. And we also do viral markers with specific emphasis on hepatitis B testing because there is a risk of reactivation of hepatitis B with CT scan, which is preferred for staging as well as surveillance. Also, we do a bone marrow biopsy, which is of prognostic stage in patients with lower stages to know whether the bone marrow is involved or not. And the response assessment is typically done with CT scan, and we use Lugano criteria. And the initial management in early stage diseases, stage 1 or 2, if there is a single site involved, we use involved site radiation therapy. Typically, 24 to 30 gray is used, or we can use rituximab monotherapy for weekly doses, usually which is used in splenic marginal zone lymphoma commonly, or we can also use active surveillance in selected cases. In stage 3 and 4, we'll see if the patient requires treatment as per GELF criteria. If the patient is asymptomatic and has low burden disease, we can use watch and wait strategy or active surveillance. And if GELF criteria is met, we initiate treatment. And these are the patients who have symptomatic disease and rapid progression. So, in first line systemic therapy with high tumor burden, the preferred combinations we use chemoimmunotherapy combinations. This is as per the NCCN guidelines. So, bendamustine plus rituximab is preferred because it is less toxic than R-CHOP. And but we have to be careful if the patient is planned for CAR T any soon. So we will delay bendamustine or avoid bendamustine. And the next best is R-CHOP or CHOP plus rituximab. And nowadays we can use rituximab or obinutuzumab, any anti-CD20 monoclonal antibodies. And the next preferred is CVP plus rituximab or obinutuzumab. And one emerging option is lenalidomide plus rituximab. And regarding obinutuzumab is a type 2 anti-CD20 monoclonal antibody, which is preferred in rituximab refractory disease or in cases where CD20 expression is less. So obinutuzumab has higher avidity and higher binding capacity with CD20. So also it is less dependent on cell-mediated complement-mediated cytotoxicity, more of cell-mediated cytotoxicity. And for first line therapy in low burden and frail patients, in low burden disease, we can use rituximab monotherapy weekly 4 doses, and they have an overall response rate of 46 to 70% durable response. And another emerging option is lenalidomide plus obinutuzumab. And we use obinutuzumab mostly in fit patients. In patients who are frail or elderly, we use rituximab monotherapy, which is common, or we can use chlorambucil in patients who are intolerant to regular conventional chemotherapy, or we can use a very shortened version with rituximab and cyclophosphamide only. And there are some trials which go by the name Prima, Gallium, and Gadolin. They have explored the role of maintenance therapy after initial cycles of chemoimmunotherapy. So rituximab maintenance with 375 mg per meter square every 8 to 12 weeks for 2 years. The Prima study shows it significantly prolongs the progression-free survival, but there is no change in overall survival. And also, there are two trials for obinutuzumab. Gallium trial, it is after frontline chemotherapy using maintenance obinutuzumab, and Gadolin trial, which is in relapsed refractory or salvage stage. After salvage therapy, maintenance obinutuzumab. Both these studies found uh, prolongation of progression-free survival. And there is one Japanese cooperative oncology group. They found non-inferiority with and without obinutuzumab maintenance. Also, obinutuzumab maintenance is used for rituximab refractory disease. And for second line therapy, selection is based on prior therapy exposure. We'll be trying to avoid repeating the first line regimen. Of course, if we ran out of all salvage options, we have to repeat. And also, we use POD 24 status, the progression of disease based on at 24 months. If the progression is has occurred less than 24 months, so we take the disease to be aggressive. And depending on CAR-T eligibility, so nowadays the trend is moving towards early CAR-T consideration in fit patients, and also depending on the disease burden. In bulky or symptomatic disease, we have to use systemic therapy. And if the patient has relapsed and still has asymptomatic or low burden disease, we can watch and wait, or we can give targeted therapy. So, in the classical salvage therapy or second line systemic therapy are BR, CHOP, and CDP, which was not used in the first line in people who are rituximab sensitive, and lenalidomide plus rituximab, and there is tafasitamab plus lenalidomide plus rituximab. And in rituximab refractory patients, we use obinutuzumab as monotherapy or along with chemotherapy. And NCCN recommends one EZH2 inhibitor, which is epigenetic, which is tazemetostat. And lenalidomide is also used in patients who are not a candidate for CD20, anti-CD20 therapy. And there are novel agents, novel combination of zanubrutinib plus obinutuzumab. And also there is one CD19 antibody drug conjugate, loncastuximab plus rituximab. And when we are starting second line chemotherapy, there is one critical consideration to have. So we have to rule out whether the patient has undergone Richter transformation. So Richter transformation is a conversion of low-grade lymphoma, which we have the presentation is about, to some high-grade lymphoma, typically DLBCL. It occurs in 3 to 5% of the patients per year in follicular lymphoma, and it carries relatively poor prognosis compared to low-grade NHL. And the typical red flags are increasing LDH and disproportionate growth of the tumor mass or single lymph node, and new B symptoms and extranodal disease. So we have to biopsy the FDG sites and we have to see for the transformation. If there is Richter transformation, we use anthracycline-based chemoimmunotherapy, which is ARCH is preferred, and we'll consider early CAR T cell therapy. And allogenic transplant, we used to consider. Now CAR T has become the previous line for allogenic HCT. And regarding CAR T cell therapy in low-grade NHL, so CD19 CAR T, anti-CD19 CAR T has been approved for among low-grade NHLs, follicular lymphoma, and apart from that, there is approved indications are DLBCL, mantle cell, as well as primary mediastinal lymphoma. And brexucabtagene is not as such approved by FDA for low-grade lymphomas. So axicell, lisocell, and tisa-cell are approved. And in India, we have Nexcar 19, which is talicell, talicaptagene autoleucel, and varnemcaptagene autoleucel, which is by Immunine. And response rates are better in low-grade lymphomas. So in follicular lymphoma, we have 70 to 95% overall response rate compared to DLBCL, it's 40 to 74%. And the CAR T manufacturing and timeline is typically takes 3 to 4 weeks for manufacturing. So if we assume day zero to the day of leukapheresis, so it takes T cell collection is done. Then for CAR transduction and expansion, it takes 2 weeks and 1 week for quality control and cryopreservation. So after product, once the product is ready and about ready for delivery, we start the patient on lymphodepleting chemotherapy and we infuse CAR T cells. So, and during this manufacturing period, we have to do something for the disease control, and which we call it as bridging therapy. So, bridging therapy is defined as any lymphoma specific therapy which is administered between leukapheresis as and CAR T cell infusion. So the goals of bridging therapy are disease control, to prevent progression of disease during manufacturing, and also it manages symptoms, disease-related symptoms, and also to reduce the tumor burden, reduce the bulky disease before infusion. Also, it is for T cell optimization. It makes space for the newly coming CAR T cells in the body. So, typically, we use bridging for bulky symptomatic disease and rapidly progressive disease and high disease burden. And in low-grade lymphomas, we always don't need bridging. For example, in patients who are early stage and asymptomatic and who have indolent disease with low burden and a stable disease, we don't need bridging. So bridging therapy can be chemotherapeutic approaches as well as non-chemotherapeutic approaches. So we can use single agent immunotherapy with rituximab with the advantages of quicker disease control and preservation of T cell function and minimal toxicity. And there is one study called Tarmac study, which have explored use of single agent BTK inhibitors. So the study found that it improves T cell expansion and function and reduces checkpoint related activation and also decreases CRS. Also, we can use radiation as bridging. If the patient has localized disease, radiation serves as a very good bridging. And the chemotherapeutic approaches are bendamustine, and usually we in less aggressive patients, and we use combination chemotherapy in patients with high disease burden or aggressive disease. So there is a study by Lion Lymphoma Consortium. They say in their study of patients of low grade NHL, around 50% of the patients received bridging, and patients who received non-chemotherapeutic bridging, they had better progression-free survival after CAR T, and patients who had received chemotherapeutic bridging had poorer overall survival. So the association is trending, but not statistically significant. Maybe this can also be possible due to patients who are not needing chemotherapy-based bridging. They might have had a less aggressive disease biology. So regarding the timing, sequencing, and optimal bridging characteristics, there are some critical guidance by NCCN guidelines. So if we are planning to use bendamustine for bridging, we delay it after leukapheresis because bendamustine impairs T cell mobilization. Also, we have to avoid checkpoint inhibitors, which which reduces the efficiency of CAR T cells. And also we use BTK inhibitors, which are preferential, which are beneficial before leukapheresis. And optimal bridging helps rapid, the optimal bridging control, I mean, the bridging regimen helps rapid disease control. It provides minimal immune suppression with preserved T cell function, and it should be of short duration, and so that the toxicity of the bridging therapy does not overlap with the CAR T cell therapy or its toxicities. So before we give CAR T cell therapy, we give something called as lymphodepleting chemotherapy. The standard lymphodepleting chemotherapy is fludarabine plus cyclophosphamide. Bendamustine is another lymphodepleting therapy, but we try and avoid bendamustine uh, because of the considerations of decreasing the efficiency of CAR T cells. And it is administered 3 to 7 days before CAR T cell infusion. So infuse till day -2. And lymphodepleting therapy enhances CAR T cell expansion as well as anti-tumor activity. And regarding acute toxicities, the most three common and four common acute toxicities are one is cytopenias, cytokine release syndrome, ICANS or neurotoxicity, and IECHS or hemophagocytic syndrome. So, cytokine release syndrome is characterized by fever, hypotension, and hypoxia, and it is mostly interleukin mediated, particularly interleukin 6. And the incidence is around 50 to 70 percentage, and higher grades, grade 3 and 4, is around 10 to 20 percentage. So management is using tocilizumab, we use around grades 2 or more, and corticosteroids and supportive care. And for ICANS or neurotoxicity, which is characterized as encephalopathy, seizures, or delirium, it occurs at a median day of day 4 to day 7 of post-infusion. And the grade 3 to 4 or higher grade ICANS is around 10 percentage, 5 to 15 percentage. With Indian CAR T products, it's still lesser. And management is with steroids, corticosteroid. Dexamethasone is preferred because of better CNS penetration with seizure prophylaxis, and we use anakinra. And for response assessment post CAR T, we usually do the first initial assessment at day 30 and subsequent at months 3, 6, and 12. We use both clinical as well as imaging follow-up. And the response criteria is by Lugano criteria. I've made a very shortened here one here. So complete response is based on PET-CT, which is on a 5-point dual scale. It is less than 3 is characterized as complete metabolic response. And partial metabolic response is dual stage 4, but no newer sites. And the FDG avidity has reduced compared to previous scans. And no response or progressive diseases, appearance of new sites, dual score 4 to 4 or 5 with increase in FDG avidity. So long-term monitoring is then for in the initial part, we monitor for CRS, ICANS, as well as cytopenia, and we look for opportunistic infections because because of lymphodepletion, the lymphocyte immunity or antibody mediated immunity will be low, and which is enhanced in the first 3 months, and it takes up to 6 to 18 months to recover. And we also monitor for viral reactivation because of the antiviral immunity is low. CMV and EBV reactivations can occur. And also we go for lifelong surveillance for secondary malignancies, which is a risk in CAR T cell therapy. And mechanisms of CAR T cell failure or mechanisms for relapse post CAR T, the most common cause is antigen loss, CD19 becoming negative. And the solution is we can do CD20, we can give CD22 directed CAR T or bispecific CAR Ts. Which is still next. No bispecific CAR T product is officially FDA approved. And the other reason for failure is CAR T cell dysfunction, exhaustion of CAR T, or insufficient expansion. So we can repeat, the solutions are to repeat CAR T, or we can give a second infusion with BTK inhibitors. And third is immunosuppressive tumor microenvironment with a checkpoint ligand expression and regulatory T cells. So there is an investigational solution. We are giving CAR T cell therapy with checkpoint inhibitors. And after CAR T cell failure, salvage options are repeating CAR T, mostly a higher generation product. So we recently had a correspondence published in NEGM from SunAct where there was an use of armored CAR T. Armored CAR T, they can produce their own interleukins. They have fourth generation CAR Ts. And we can add BTK inhibitor and also, apart from that, we can use bispecific antibodies. Post-CAR T relapse, bispecific antibodies are the ones which we have as the next available thing in our armamentarium. Also, we can use allogeneic stem cell transplantation. And beyond third line, we have bispecific antibodies. In low-grade lymphomas, glofitamab is there, which is anti-CD20, and there is epcoritamab. And these have an overall response rate of 65 to 85 percentage in relapsed follicular and marginal zone lymphoma. And before giving this anti-CD20 bispecifics, we do a biopsy again and we confirm the CD20 positivity. And again, we have CAR T cell therapy, which we can use either a different product or a different generation or product. And we can use alternative agents. We can use BTK inhibitor. Also, we have EZH2 inhibitor, just tazemetostat. And in special situations, in patients with rituximab refractory disease, we prefer obinutuzumab, or we can with along in combination with tazemetostat or Bruton tyrosine kinase inhibitors. And in these patients, we consider early CAR T, not to wait for multiple lines. And patients who are elderly and frail will adapt the regimens. When we are using uh, chemoimmunotherapy, we use single agent rituximab instead of full R-CHOP. And if the patient is fit for CAR T cell therapy, we can use a bendamustine based conditioning regimen as well. And also we decide the treatment plan based on the patient's life expectancy. And in young patients of reproductive age, we use fertility preservation. And in pregnant patients, rituximab is compatible, but we have to consider the timing. And chemotherapy, we try to avoid chemotherapy in patients with reproductive age group. And specifically for follicular lymphoma, as an example, for stage 1 or 2, early stage, we use involved site radiotherapy or single agent rituximab or active surveillance. In stage 3 or 4, we'll decide whether to treat them based on the GELF criteria. If the patient is having low burden disease and we are intending to treat, we use single agent rituximab or rituximab plus lenalidomide. The patient is having higher burden based on the patient's fitness. We can use low intensity regimens like bendamustine rituximab or rituximab plus lenalidomide. Or if the patient is able to tolerate, we use R-CHOP and we follow that with maintenance rituximab or obinutuzumab based on the disease response. So the key takeaway is active surveillance is also a standard for asymptomatic low burden disease. Rituximab, which revolutionized the treatment for B-cell lymphomas, remains the backbone of therapy still. And maintenance rituximab for 2 years significantly improves progression-free survival, but there is no change in overall survival. Cell therapy is now preferred for relapsed refractory stage, and it is moving up the lines. And bridging therapy is used judicially, and not all patients need it, and we determine the need for bridging therapy on an individual case-by-case basis. And we avoid bendamustine before leukapheresis because it reduces the T cell function. And before we start a salvage therapy, we always consider histological transformation, which is confirmed with biopsy. And BTK or Bruton tyrosine kinase inhibitors before leukapheresis is known to enhance CAR T cell function based on recent trials. And we personalize treatment based on age, comorbidities, life expectancy, as well as for CAR T cell eligibility. So, in the new things in low-grade NHL are bispecific antibodies CD3, CD20, and CD3, CD19. And CAR T cell therapy is moving earlier in the disease course. And the newer combinations with CAR T cell therapy are being studied. CAR T cell therapy with BTK inhibitors as well as checkpoint inhibitors. And CD20 directed CAR T cell therapy for CD19 relapse, and also bispecific CAR Ts are also under trials. And MRD monitoring is being considered as for prognostic value. So these are my references. And if you have any questions,